Hi, my name is Darren Jaquist. This is Substance-Induced Psychotic Disorder Diagnosing and Treating for GMHC 550 with Professor Dr. Macy Stead. This is a slide that I put together as a joke, as a fake cover slide for my presentation. It's from the movie Super Troopers. The gentleman in the back seat, in an attempt to hide their magic mushrooms from the police officer leaning in the window, had eaten a whole bag of them, and he was starting to hallucinate from having taken them all. And one of the things he says to his buddies in his state of acute intoxication is the Snozberries taste like Snozberries, which is from the movie Willy Wonka and the Chocolate Factory. But as I'll discuss later, that's really intoxication from a substance and not the substance-induced psychosis as covered in the DSM-5. This book by Dr. Oliver Sacks is one of the books I came across in doing my research for this topic, and I highly recommend this book. I think it is a fantastic read, and really anyone who's dealing with clients or patients who may have psychosis should read this book. This book is essentially entirely about all of the ways in which delusions and hallucinations can manifest in disorders other than schizophrenia, and substance use is talked about in this book. And there's this definition that I have up there on screen, which is partially covered by my camera, and I'm just going to go ahead and read from the book. I really like this. It says, they are volcano-like eruptions from the lower levels in the brain, the sensory association cortex, hippocampal circuits, and the limbic system. They are also shaped by the intellectual, emotional, and imaginative powers of the individual, by the beliefs and style of the culture embedded. And I'm going to talk a little later in this presentation about culture and its effects on delusions and hallucinations, but I thought this was a really good definition from a really great book that I was really impressed with just all the different ways other than delusional disorder or schizophrenia in which hallucinations and delusions can manifest. So again, highly recommend this book. Okay, a quick overview of substance-induced psychotic disorder. Let's start with how the DSM-5 defines psychoticism and psychosis. Exhibiting a wide range of culturally incongruent, odd, eccentric, or unusual behaviors and cognitions, including perception, association, content, and beliefs. Now, I want to talk just real quick as a refresher on the difference between hallucination and delusion. Hallucination is a disturbance in perception, something that you actually think is there that isn't real. A delusion would be a belief that isn't real. An example would be if I believe I'm the crown prince of Denmark, that would be a delusion. If I am having conversations with the ghost of my murdered father, King Hamlet, that would be a hallucination. So delusions and hallucination with lack of insight. I have lack of insight on there because if the person is aware that the things that they're perceiving aren't real, then it wouldn't rise to the level of a disorder. And, it's interesting, Dr. Sacks, in his book that I had mentioned before, he experimented with a lot of different substances and had hallucinations, and he took notes, and he knew very well what was happening to him at the time wasn't real, and so his own experiences wouldn't have risen to the level of giving him a diagnosis. Symptoms generally dissipate with cessation of use. I'm going to talk more about that. That is really a key with this particular disorder. It's not better explained by withdrawal or intoxication, and it's not better explained by a primary psychotic disorder. Okay, quickly, the DSM-5 diagnostic criteria, you'd have delusions and or hallucinations. The symptoms developed while using or soon after intoxication and withdrawal. And the symptoms are not better explained by a primary psychosis or delirium, and have persist 1 month or longer on there. This is one of the ways you would differentiate the substance-induced psychotic disorder from intoxication from the substance or from withdrawal from the substance. If you suspect it's one of those two things, you wouldn't diagnose under this category. And I'm going to go into more detail on how you differentiate that. But generally speaking, the hallucinations and delusions can last for up to a month after cessation of use of the substance, depending on what the substance is. And so within that first month, you would have a tendency to suspect either intoxication or withdrawal. And I'm gonna, like I said, I'll talk more about how you differentiate that from a primary psychosis later. And so the last criteria I have on there is clinically significant distress. And that goes back to, like I mentioned before, with insight. If the person understands that what they're experiencing is not real, then you wouldn't generally give this diagnosis. So regarding treatment of substance-induced psychotic disorder, I didn't find really any professional disagreement on what the treatment for this disorder is. It's quite simple. It's cessation of the use of the substance that you suspect is causing the psychosis. It does get more complicated if you suspect substance use disorder is present. And this is an important distinction because you can have a, a psychotic event from a substance from a single use. You wouldn't generally diagnose someone with a use disorder on the basis of one-time use, but the psychosis can result from a single use. So if you have a comorbidity there, it does get more complicated, and you can parse that out with the assessment tools. And I have a slide later about what the best tools to use are. So the difficult part with substance-induced psychotic disorder is the diagnosis. And the reason is because of what you want to rule out. You want to rule out acute intoxication from the substance, and surreptitious use can be a problem. Clients aren't always forthcoming about their usage because of the stigma attached and the legal ramifications if they think they might get caught, and they might have criminal penalties involved for their use if it's illegal drugs. And you want to try and rule those things out. You also want to rule out withdrawal. As I mentioned, withdrawal symptoms can persist up to a month, and you can have all the symptoms of psychosis as part of withdrawal. And then you also want to rule out a primary psychotic disorder, and I'm going to talk again in a later slide about how you are going to go about that. But it's essentially you're going to rely pretty heavily on those other diagnostic instruments and the history. And you're going to want to try and rule out a neurobiological cause. And I know that's a little outside our realm here as counselors. We're not medical doctors. But if you suspect that there is a medical cause, you'd want to refer that out and get a medical. More information on diagnosing. As I mentioned before, the patient mental health history is going to be important. If you're dealing with someone who has a prior history of delusions and hallucinations, and it perhaps doesn't have anything to do with substance use, you may suspect a primary psychotic disorder such as schizophrenia. If the symptoms persist past their acute intoxication, past withdrawal, for most substances, that is all over within a few days, 3 days typically. Sometimes weeks. And as I mentioned before, that 1 month period is pretty key. You're rarely going to see intoxication or withdrawal, psychotic symptoms because of intoxication and withdrawal past that 1 month. And particularly if you get to that 6-month spot, I didn't find any information on anybody having any type of intoxication or withdrawal psychotic symptoms past that 6 months. So you're definitely going to suspect something else if you get to that 6 month marker. Typically, the most likely culprit at that point would be a primary psychosis, like schizophrenia. So when you see someone who has a sudden onset, it's their first psychotic break, they have no significant mental health history with other psychotic symptoms, and you know that they have recently used substances, that's your likely candidate for diagnosing this particular disorder. Oh, and I'll also mention that the title of this is substance-induced psychotic disorder, but depending on the substance involved, that would be your actual diagnosis. So if you know the person was using alcohol, for example, and they had psychotic symptoms, that would be alcohol-induced psychotic disorder or methamphetamine-induced psychotic disorder. You just name the substance. These are your useful instruments you're going to want to utilize when you're diagnosing this disorder. These, you could find these, they're all listed out in the Pomeroy textbook. I have that reference up there on top. The Michigan Alcohol Screening Test, the Drug Abuse Screening Test, the Substance Abuse Subtle Screening Inventory, the SASI, that's got a nice name, and the Clinical Institute Withdrawal Assessment for Alcohol and Drugs. Depending on the results of these assessments, they should give you good information as to whether or not you think this person likely has a comorbidity, like a substance use disorder, or possibly it might point you in the direction of whether or not they have a primary psychotic disorder. Important considerations when you're dealing with somebody that you suspect is afflicted with this disorder. I want to really stress that withdrawal is potentially fatal. And you will have clients who try to quit their substance use cold turkey, and you will have people who really think that the best course of action is to just quit, get somebody off whatever it is that they're using. And with chronic users, I can tell you without a doubt that if they're chronic and they've been chronically using a lot, you will want to have those people detox under medical supervision. One of the most deadly withdrawal substances is alcohol. And then one of the texts, I forget which one now, did mention that cocaine is typically not ever fatal from withdrawal. It can be extremely unpleasant, but it's typically not fatal. So I want you to remember that. Another thing to remember is denial. Denial is a real problem with people, particularly people who have substance use disorder. If they will not view their usage as problematic, and so they will deny that they have a problem with it if in fact they do have an SUD. There is stigma. I talked about earlier that surreptitious use. You may have a problem with that. They won't want to come forward, admit to how much they've used or what they've used. So that is an important thing to take into consideration. As I mentioned, the fear of repercussions. There's possible legal ramifications for admitting to what they've been using if they're illegal substances. This statistic I have on here on the next bullet point, that up to 74% of patients with a substance use disorder have a comorbid serious mental health issue. So this is where it gets really complicated, I think, when you're trying to parse out, because you could have a client who does have a substance use disorder, who does also have schizophrenia, who is also experiencing a substance-induced psychotic disorder. And so to parse all those things out, it becomes difficult. And from what I've read, the most common practice is to get the substances out first. Get them off the substances and get them past that intoxication and withdrawal. And then once those psychotic symptoms from that have subsided, then you can kind of deal with what the other underlying mental health disorders might be. So another important consideration, we're not talking about just hard drugs here. Over-the-counter medicines have been known to cause psychotic symptoms. So you need to make sure you know everything that they're taking. It's relatively rare for common household over-the-counter medications to cause psychosis, but it is possible. Alcohol, of course, is a legal drug, and that can cause psychosis. That's perhaps not as well known outside of our field, that alcohol can induce a psychosis. Suicide is definitely something you want to be on the lookout for. Suicidality with folks who have schizophrenia comorbid with a substance use disorder, and then you mix that with intoxication, and the suicide risk is really, really high for people who meet all this criteria. So you definitely want to continually assess the suicide risk if you have somebody who is getting this diagnosis and may have other comorbidities. And then, as I mentioned, I loved that Dr. Sachs book, The Consequences of Labeling Somebody as Schizophrenic. I mean, that can follow them around a long time until they get a correct diagnosis, if ever, if they ever get a correct diagnosis. And that book that I read, he details many different instances where he had patients who had a schizophrenia diagnosis when what they really had was something other than schizophrenia. I specifically remember there was a case where someone had PTSD and they had hallucinations associated with their PTSD. And so there are many other diagnoses. So you want to make sure you're getting it right before you code somebody as a schizophrenic. So pharmacological and cultural considerations. Pharmacological, as I mentioned, if you get somebody past intoxication and withdrawal, the psychotic symptoms are going to go away. So you're not normally going to need to put somebody on antipsychotic, but it can be done, and it is sometimes done, particularly if those symptoms last beyond that 3 day to 1 week window is when you would typically see the psychosis symptoms dissipate. Although, again, this is one of those situations where if you're trying to figure out for certain whether or not somebody has um, a primary diagnosis that's different from a substance-induced psychotic disorder, you don't necessarily want to put them on antipsychotics immediately until you can make that diagnosis. But it is available, and it can be done. So mood stabilizers, that's the next bullet point. They're also used. Anxiety can be sky high when someone is going through withdrawal, and depression. And so I've got the benzodiazepines are typically used for that anxiety with withdrawal, and then the mood stabilizers for you can have depression and hypomanic states that also manifest in that period. Um, the next couple bullet points on this slide are cultural considerations. If you remember that quote that I had at the beginning from Dr. Sachs, he talks about hallucinations and delusions tend to manifest in ways that are culturally significant, culturally appropriate. So people who have different ideas and beliefs in their religious upbringing or just part of their cultures will have a tendency to manifest in their delusions. And I remember a case from one of our previous classes, and I don't remember which textbook it was in. I went and looked for it, but I couldn't find it. But I remember there being a case study where we had a person who was coming in, and English wasn't his first language. And um, what he used to describe, I think it was headaches, but he called it spirits, and he ended up with an initial diagnosis of schizophrenia because that was the word he used. It was spirits, but it was a colloquialism, and it was really more like headaches, and it wasn't spirits. But the doctor who had diagnosed thought that he believed that he was being attacked by spirits. And then lastly, from a cultural standpoint, we need to understand the culture that people come from, or at least have a basic understanding of it. And we want to avoid pathologizing their cultural beliefs about what happened to them. If they have cultural beliefs about what happened to them, we certainly don't want to use that as a basis for deciding that they have schizophrenia, for example. Quickly, I want to tell you about a friend of mine who had a substance-induced psychosis. This was from alcohol, and I changed his name. I've changed it to Frederick H. He's a friend that I have through Alcoholics Anonymous. He gave me his permission to tell his story, and this isn't me with me changing the name. So he had this belief that the Earth was coming to an end, and that he had this ability to communicate with dolphins. He was in Hawaii at the time, and he ended up deciding he was just going to swim out and go live with the dolphins. Some fishing boat found him out there, and they rescued him. And long story short, once he got sober, he made a full recovery, and his hallucinations and delusions went away. Quickly, these are the takeaways from my presentation. Cease use, possibly under medical supervision. Symptoms will probably go away if it's this disorder. Remember, withdrawal is potentially fatal. Be wary of giving the schizophrenia diagnosis too fast. Full recovery usually comes with sobriety, and you definitely want to reassess the psychotic symptoms after 1 month for a possible primary diagnosis. Thank you. And these are my references.